Well, hello everybody. Welcome to today's Neurology Grand Rounds. My name is Eoin Flanagan. I'm a neurologist here. Many of you will know me. I work in the neuroimmunology area of autoimmune neurology and multiple sclerosis. And I also work in the Department of Laboratory Medicine and Pathology, where I work in the neuroimmunology laboratory. And today, I'm going to talk a little bit about autoimmune encephalitis diagnosis and misdiagnosis. So the learning objectives today are to learn how to diagnose autoimmune encephalitis. We will identify red flags that suggest alternative diagnoses. We'll discuss about neural autoantibody interpretation and putting test results into clinical context and the potential for false positivity. Here are some of the disclosures for the people who organize the grand rounds, and my disclosures are here too, but they're not really too relevant to this talk, which will focus almost exclusively on diagnosis. I'll briefly mention in some cases a variety of immunotherapies, but really the focus today is on diagnosis. So if we think about the history of autoimmune encephalitis, there was a seminal article in 1966, a report of a case from a person named Lord Brain, who reported a patient who presented with encephalopathy and delirium, and also had stroke-like episodes, and this patient had a history of Hashimoto's thyroiditis. And the patient did not respond to prednisone at the time, but eventually improved, and it was thought that autoimmune mechanisms were at play. And this led to the term Hashimoto's encephalopathy, which was one of the original terminologies used to describe autoimmune encephalitis in patients who had thyroid antibodies. And later, some Mayo Clinic investigators, including Dr. Beauvais, were involved with a study on steroid responsive encephalopathy associated with autoimmune thyroiditis, or SREAT, S-R-E-A-T. Now, what we've learned over time is that there are much better biomarkers than thyroid antibodies. And indeed, as I'll talk about later, these thyroid antibodies can be a little bit problematic. But there's been a wide variety of neural antibodies discovered. And if we look here at this picture dating back to 1960, this was a slide provided to me by Dr. Sean Pittock. And what you'll see here is antibodies on the top are antibodies that target nuclear or cytoplasmic proteins. We'll come back to that a little bit later. And then down below here, you'll see antibodies that target plasma membrane proteins. So you'll see some seminal antibodies here. The aquaporin 4 discovered by Dr. Lennon here at the Mayo Clinic was a very important discovery. Here we see NMDA receptor antibodies, which really triggered a number of new studies into other antibody biomarkers of autoimmune encephalitis. And you'll see others here, AMPA receptor, DPPX, and even more recent ones, Kelch-like protein 11 discovered here at Mayo Clinic, GFAP antibody also discovered here at Mayo Clinic. So we'll discuss some of these today, but the bottom line is that really in the last 20 years, there's been a huge explosion in the number of antibody tests that are available, and these are very good biomarkers for us to use in clinical practice for diagnosis. Dr. Dubé and I participated with our group in a study looking at the frequency of autoimmune encephalitis, and we looked at that here in Olmsted County. What we found was that it was similar to infectious encephalitis. The prevalence was 13.7 per 100,000 for autoimmune encephalitis versus 11.6 per 100,000. And what we found in this study was that over time, here we can see 2006 to 2015 in gray and 1995 to 2005. And what we found was that there was a threefold increase in the incidence of autoimmune encephalitis, and that was driven mostly by these antibody biomarkers. So now we could make a diagnosis in a patient who was previously labeled as an idiopathic encephalitis or a presumed infectious encephalitis. And if you looked in the study over the same time period, the infectious encephalitis did not change much. Testing has not changed as much, although we know that next generation sequencing is now available. And others have also shown this increasing detection over time. And indeed, autoimmune encephalitis has kind of overtaken in terms of the frequency, the classical paraneoplastic disorders. And we'll talk about autoimmune encephalitis today. So first question is, how do we recognize autoimmune encephalitis? Well, some patients will have a preceding viral syndrome. That's very common with the MOG antibody and indeed with other antibodies. So we have seen patients who have some sort of infectious syndrome. We've even seen it post-COVID where patients can develop some sort of encephalitis. Herpes simplex virus encephalitis we'll talk a little bit about later. We can see NMDA receptor encephalitis after that infection in the brain. And then weight loss can be a feature of one particular antibody called DPPX, where patients sometimes initially present with severe weight loss, an average of 20 kilograms, and they can also have diarrhea. When we think about the clinical phenotype of autoimmune encephalitis, we need to distinguish it from the neurodegenerative disorders, which are more insidious and slowly progressive over time. So really, these disorders are generally quite subacute. They come on over days to weeks, and they have a rapid progression. So they more mimic a rapidly progressive dementia than an insidious dementia. Patients commonly have seizures in addition to the encephalopathy, but patients can have multifocal other involvement in the central nervous system or the peripheral nervous system or the neuromuscular junction, either concurrently or subsequently when they present. There are some other aspects that are important to ask about. Just like in neurodegenerative disorders, sleep evaluation is becoming more important, and we tend to ask about patient sleep. And I think the same is true for autoimmune encephalitis. The IGLAN5 antibodies are the characteristic antibody, and I know there's been cases of that presented at the CPC here before, where patients can have prominent parasomnias. Also, patients can have narcolepsy cataplexy from involvement of the hypothalamus with MAT2 and aquaporin 4 antibodies, for example. Insomnia is a major feature of Morvan syndrome, which we'll show an example of. And laryngospasm can be seen with ANA2 antibodies or anti-Re. It's good to ask about hearing loss. This can help you with your diagnosis of autoimmune or paraneoplastic encephalitis, particularly with the Kelch-like protein 11, but it also brings up an important differential diagnosis for diseases on the spectrum of autoimmune encephalitis, like CNS vasculitis, where hearing loss might be more common, and also Susak syndrome and mitochondrial disorders would also be on your differential diagnosis. So useful to analyze that when you're seeing your patients. It's also useful to ask or to look for visual changes. So we know that retinopathy can accompany CRIM5 autoantibodies, and optic neuritis can accompany MOG or aquaporin 4 antibodies. So these are things to look for on your history and your examination. Some other aspects, it's important to ask patients if they have a history of cancer, particularly small cell lung cancer. We know that sometimes patients can present with their first presentation of a paraneoplastic encephalitis in the setting of a cancer recurrence. So that can be important. And while most patients present prior to the cancer being known, some patients can present after the cancer is known. It's also important to ask patients about a history of autoimmunity. If a patient has a history of Graves' disease, type 1 diabetes, other autoimmune conditions, then we might be more suspicious that they may have a concurrent autoimmune neurologic disease. Transplant, I'll talk a little bit about later. We found some cases of autoimmune encephalitis in the post-transplant setting. Medications are important. Immune checkpoint inhibitors, Dr. Zakaridu, I know, has talked about some of the CNS complications to us before associated with immune checkpoint inhibitors, and CAR T treatment can be associated with somewhat of a cytokine storm, and that can be important in the evaluation of presumed autoimmune encephalitis. We ask about smoking because we're interested in if patients might have small cell lung cancer. We'll ask about a family history of autoimmunity. And then it's important on your examination and quite useful if you're seeing these patients to quantify the neurologic deficit. I think it's quite helpful when you follow up with the patient to see how much they might have objectively improved, particularly if there's any diagnostic uncertainty and you give a patient a trial of steroids. It's useful to quantify their deficit with initial cognitive testing. For children, there are certain disorders to look out for. The MOG antibody is going to be probably the most important in children, where patients will often have an ADEM or acute disseminated encephalomyelitis-like presentation, but also aquaporin 4 antibodies can be seen in this group. And then GABA A receptor antibodies, which is something that we can test for on a research basis, can have similar MRI findings and has a reasonably high proportion of children involved. Psychosis encephalitis or post-HSV encephalitis, we think about NMDA receptor antibodies and the potential for an underlying teratoma. Although younger children don't tend to have teratoma as much, teenage females would be a common association with teratoma. And opsoclonus myoclonus can occur in the setting of autoimmune encephalitis with ANA1 or anti-Hu antibodies and an underlying neuroblastoma. So these are some particular disorders that we think about in children. Some of the other antibodies can occur in children, but these are the most common, I would say. And then we can also think about the characteristic clinical syndromes. So there are certain syndromes where if you see them, you really want to think about ordering antibody testing. Fatiobrachial dystonic seizures is one with LGI1 antibodies. Opsoclonus myoclonus is another, where you can have ANA2 antibodies or ANA1 antibodies in children, as we mentioned. Morvan syndrome, I'll show later, associated with the Caspr2 antibodies. Limbic encephalitis, there's a wide range of antibodies, but this is a high-risk situation. ADEM is another situation where you really want to be ordering your MOG and your aquaporin-4 antibodies. We have a syndrome called progressive encephalomyelitis rigidity and myoclonus, or PERM syndrome, associated with GAD65 and glycine receptor antibodies. And then we have patients who develop a subacute and progressive ataxia, what we term paraneoplastic cerebellar degeneration. So these are some of the syndromes where really you want to be ordering antibodies in serum and CSF in all of these patients. And then, of course, we have the psychiatric syndrome that's been described with NMDA receptor encephalitis, where patients can initially present with psychiatric symptoms and then develop a more full-blown encephalitis, and that's particularly common in young women. And when we're evaluating a patient with autoimmune encephalitis, in addition to looking for some of those clinical and neurologic examination features, we'll also often obtain an MRI scan. And MOG antibodies is something that I'm interested in at the moment. And I'll just show some examples here of some imaging. Here we can see these multifocal white matter T2 hyperintensities in a patient with ADEM. This patient we'll talk about later as a case example. We can also see a unilateral hemiencephalitis that we can see here, where patients get swelling of the cortex and sometimes some leptomeningeal enhancement. And you can see signal abnormality within the sulci here compared to the normal other side. So these patients can present with seizures, with fevers, with headache and encephalopathy. When we see the brainstem lesions in MOG antibody disease and the cerebellar lesions, we can see these large, fluffy T2 hyperintensities in the middle cerebellar peduncle, or diffuse lesions within the brainstem. And that's a bit different to MS, where we have smaller, more focal, well-defined lesions. This is an example of the classic limbic encephalitis. This is unilateral here in the left mesial temporal lobe. You can see this T2 hyperintensity in a patient with LGI1 antibodies. We can also sometimes see signal abnormalities within the basal ganglia. This was a patient referred by Dr. Watson to us in the autoimmune clinic when I was a fellow, who had an autoimmune chorea associated with CRIM5 antibodies. And you can see the signal abnormalities here within the basal ganglia. We can also see deeper signal abnormalities. This was a patient with MAT2 antibodies that we shared with Dr. Silber. And what you can see here is this T2 hyperintensity here adjacent to the third ventricle in this patient who presented with a narcolepsy cataplexy as part of their autoimmune encephalitis. And then, as Dr. Axmed first recognized, this pattern of linear radial enhancement coming outward from the ventricles here in patients with, which was later found to be GFAP antibodies. Dr. Axmed had initially seen some of these patients in his clinic and had collected them, recognizing this clinical radiological syndrome. And subsequently, we were able to determine, Dr. Lennon was able to discover that these patients did have, in fact, have antibodies to GFAP. I will mention that with NMDA receptor antibodies, and indeed with some of the other antibodies, sometimes we can have a completely normal MRI. And I would say that the majority of patients with NMDA receptor encephalitis will have a normal MRI. And in that situation, the antibody itself becomes more important because the diagnosis may not be so obvious. In this case, with limbic encephalitis, the diagnosis is obvious, but if the MRI is normal, people might not be suspicious for an autoimmune encephalitis. We use the EEG also when we're evaluating patients with autoimmune encephalitis, and we use this to look for epileptiform activity. So we'll be looking for sharp waves, spikes, clinical or subclinical seizures, and that helps distinguish from neurodegenerative disorders where usually we don't see those changes. We also will often see generalized or focal slowing, although that can be common across a broad range of differential diagnoses, so is not as distinguishatory. And then fatiobrachial dystonic seizures, as I mentioned earlier, those episodes are very short-lived and often don't have much scalp EEG correlate, and sometimes they're labeled as non-neurologic or psychiatric disorders because of this. Extreme delta brush is a pattern where we can see these slow waves with superimposed beta waves on top of each slow wave that has been titled the delta brush and can be seen with anti-NMDA receptor encephalitis, although can sometimes be seen with other conditions. But if you see that, you want to think at least about NMDA receptor encephalitis. We also analyze the spinal fluid in these patients when we're evaluating for autoimmune encephalitis, and we're looking for two major things. Firstly, we're looking for an elevated white blood cell count, and we're looking for elevated oligoclonal bands or IgG index. I think the protein and glucose are not as useful in these cases, as that tends to overlap with other conditions, but these initial parameters are quite useful to give you a clue. In many cases of autoimmune encephalitis, probably 70 to 80% will have inflammation detectable in the CSF. The CSF is also useful, of course, to look for alternative etiologies. So we'll often do a meningitis encephalitis panel. We'll be looking for things like herpes simplex virus encephalitis. We can also evaluate for neurodegenerative conditions or other infections like CJD with an RT quick test that's sent to Cleveland, to the virus reference lab there, to the Prion reference lab there. And we can also do next generation sequencing now, where we can look for a wide variety of different organisms. We also can look at cytology and flow cytometry because lymphomas and other neoplasms come on the differential diagnosis. And then we can also look for degenerative markers like amyloid beta 42 and phospho-tau, which can help us as we're looking into the differential diagnostic possibilities. And then, of course, we'll often do antibody testing in the CSF. We'll also often do that in the blood. And we'll focus here on antibody testing for a little bit. So just to mention, the mainstay of our testing in our neuroimmunology lab is that we'll run the serum and CSF on a composite of mouse tissue, what we call indirect immunohistochemistry. And what here you can see is this lighting up brightly in the hippocampus here and in the granular layer in a patient with NMDA receptor encephalitis. We also have a patient with CRIMP5 autoantibodies lighting up brightly in the myenteric plexus, and a patient with anti-Hu or ANA1 antibodies lighting up here within the cerebellum. So we use this as our screening test to look for many of these antibodies. And then we can do confirmatory tests. So sometimes we'll do a Western or line blot to look for PCA1, for example, or to look for ANA1 or anti-Hu. So that can be useful. CRIMP5, we can also do that. We also use the immunoprecipitation test. I will say that this is a bit more prone to have low positive results in patients with hypergammaglobulinemia, or patients, for example, who've received IVIG may have low positives on some of these tests. It's a little bit more sticky, a little bit of an older generation technique. We use this for GAD65 autoantibodies, for some of the older ones like ganglionic acetylcholine receptor antibody, N and PQ type calcium channel antibody. Another way we can do this, and this is something we're looking at on a research basis, is if we were to have astrocytes or brain cells in neurons in a dish, and then we could look and see if there was binding to live neurons in a dish to see if that was suggestive of autoimmune encephalitis. And then one of the newer techniques that we do that has proved to be really helpful in improving our specificity is these cell-based assay. This is an example of HEC293 cells where they're transfected with the NMDA receptor on the surface here. And you can see the bright binding here, while in the background there's other cells that are not staining, that don't have the NMDA receptor on the surface. And that way we can identify NMDA receptor antibodies. This is more of a fixed assay where the cells are killed or inactivated. We can also do it with live cells, which is what we do for the aquaporin 4 and the MOG antibodies. There are some other techniques. We can also use ELISA. We don't tend to use that quite as much in our laboratory. And really, we're moving towards the tissue immunohistochemistry in combination with the cell-based assay is optimal for optimal specificity. So when we think about the neural antibody testing, we can think about what the goals are. So one, it's to make a diagnosis. As we mentioned earlier, we've discovered a whole array of new antibodies have been discovered by many laboratories, and these are very helpful in confirming a diagnosis of autoimmune encephalitis. The antibody test can also help with cancer prediction. So one or more than one antibody positivity can direct you towards what type of underlying cancer there may be. It can help with our treatment decisions. For example, with LGI1 antibodies, they tend to be very steroid responsive, and prolonged oral steroids tends to be quite effective. So that can help us if we discover the antibody. And also, we'll talk in general about the antibodies to cell surface versus intracellular targets. And then it's helpful to us for prognosis, as I'll talk over the next few slides. So if we show an example of a case, and I've shared this case to some of you before, but this is an interesting case, a very severe case. This was a 47-year-old man who presented initially with the subacute encephalopathy and myelopathy that progressed to coma and quadriplegia, and he was transferred to our neuro ICU from outside, and he was mechanically ventilated. So very sick, really as sick as a neurology patient can get. And this patient had an inflammatory spinal fluid, but no oligoclonal bands. And the brain MRI showed these white matter changes that would be in keeping with what we think about with ADEM. And it was also involved into the spinal cord, again, which can occur with ADEM, with this somewhat longitudinally extensive lesion, or maybe incomplete longitudinally extensive lesion here. This patient had MOG antibodies detected at high titer. And we screened him for cancer, but we don't generally see cancer with MOG antibodies. And indeed, in his case, it was negative. And the diagnosis was MOG antibody-associated disease. And this patient was treated with IV steroids, plasma exchange, and a steroid taper. And he came back to my office 3 months later, and he was almost completely normal. So he went from being in a coma and quadriplegic back to almost completely normal. So you can see with these antibodies to cell surface targets, they have the potential for a good response to treatment and good prognosis. So again, when we think about these antibodies, we think about these two categories. And the first category is the antibodies to cell surface or synaptic antigens. That will include the NMDA receptor, the aquaporin 4 receptor, the MOG, as we mentioned. And these have the potential, at least, to be directly pathogenic, and some of them have been proven to be pathogenic. And we can see that the antibody can bind here and have an effect on the receptor here, where you may get internalization of the receptor, dysfunction of the receptor. You may recruit other immune cells in antibody-dependent cellular cytotoxicity. It may result in complement activation. So you can see that this can all be driven by the antibody. And these cases have a lower risk of cancer than the antibodies to intracellular antigens, and they tend to respond well to treatment, like the case that we just mentioned, and overall have a reasonably good prognosis. And this is typical of the antibodies to intracellular antigens. Other examples would be the Purkinje cell cytoplasmic antibody type 1, or anti-Yo, or ANA1, or anti-Hu. And again, these we don't think are not directly pathogenic because they can't cross the cell membrane to get access to the cytoplasmic or nuclear antigens. And it's thought to be driven mostly by CD8 T cells, which target the MHC class 1 when these peptides are uploaded onto the surface of the cells. And they have a very high risk of cancer. So these patients will have an 80 to 90% risk of cancer most of the time. And they tend to have a poor response to treatment and poor prognosis. So I'd like to just go over some principles of neural antibody testing that we came up with in some articles. So I think the first thing to mention is test only if there's a reasonable suspicion. So if you have a 90-year-old female who has a history of mild cognitive impairment and comes into the emergency department encephalopathic, they probably have a UTI, and that's going to be the reason for their encephalopathy. So you don't want to test your neural antibodies on that patient, for example. Also, I'll mention here that Dr. Dubé has done many studies showing the predictive value of and some scoring systems that can help you decide when to order the antibody testing. Another principle is to send before treatment. So you don't want to remove all the patient's antibodies with plasma exchange and then send a sample, because that will be negative, or you don't want to flood the system with antibodies with IVIG and then send a sample, or with rituximab, which may reduce the production of antibodies. So you really want to try and send before treatment. In general, it's best to test serum and CSF. There are different antibodies that are better detected in serum, for example, LGI1 antibodies, while NMDA is better tested in CSF. And I think if you have a high suspicion, it's hard to remember all of these, which is higher in serum and CSF, so it's good to send both. It's better to test a panel of antibodies, not one at a time. So we now have, as I showed earlier, maybe 40 antibodies that can associate with autoimmune encephalitis. And if you tested one at a time and it takes a week to 10 days to come back, the patient's not going to be doing very well if you're on the 39th antibody and you've not yet discovered it, and then it turns up. Confirmation by two techniques yields higher specificity. So if we have a tissue-based immunofluorescence and then confirmation with the Western blot, that will give us higher specificity. And then people who order here at the Mayo Clinic don't have to worry about this, but if you do test a sample from outside and it goes to a commercial laboratory, it can be worth, if you have a high suspicion, sending it to a research laboratory at Mayo Clinic, where we will look for unclassified antibodies or things not yet discovered or commercially available. There are some pitfalls of antibody testing. So some of the older generation techniques, and we'll focus in on this a little bit later, increase the risk of false positivity. Detection by Western blot alone has a high risk of false positives. We don't do that here at Mayo Clinic. So in general, we pair the Western blot with the tissue immunofluorescence because there's a high risk of false positivity. And a positive antibody should not replace your clinical judgment. So we're all neurologists. So if a patient has a positive antibody, we always need to put it in clinical context. Sometimes on the outside, when if people don't have enough time to evaluate the patient, sometimes they focus in on the antibody results rather than the patient's clinical syndrome. And a negative test does not exclude autoimmune encephalitis. So you can still have an autoimmune encephalitis with negative antibody testing. And serial testing is not really that useful. We make most of our decisions based on clinical grounds. So we don't tend to follow the antibodies quite as much. For most of the case, there are some rare exceptions like MOG antibodies, but in general, the antibodies are good diagnostic biomarkers. But if a patient develops a clinical relapse, we're more interested in that than if their antibody is still positive. When you're testing at Mayo Clinic for autoimmune encephalitis, if you're testing in children, you want to consider the pediatric autoimmune CNS evaluation in serum and CSF. That includes MOG and aquaporin 4 antibodies. And MOG has a high predisposition in children. About 50% of cases are in children. So that MOG antibody is included there. In adults, you want to order the autoimmune encephalopathy panel in serum and CSF. You don't want to order the paraneoplastic panel because it's not comprehensive enough. We don't do a lot of the cell-based assays. We don't do GAD65. So you have a much higher chance of missing a case. So in general, you want to follow the syndrome. And now we have many other syndromic-based panels, like we have a myelopathy panel. We have a movement disorder panel. So I think it's best to follow the panel. Probably in the future, the paraneoplastic panel will eventually be weeded out and we'll have just syndromic-based panels. Some other considerations, the MOG antibodies, the MOG is a little bit sticky. So we do see some binding in patients who have other neurologic diseases. So we don't have that on our panel for autoimmune encephalitis. But if you have patients with multifocal white matter changes or unilateral encephalitis that I showed earlier, you want to think about that. And then MAT2 antibodies can be tested through Athena Diagnostics. Searching for cancer, as many of you know, will often start with a CT body, and then a PET CT should be considered if the CT is negative. And I will say that there are many cases where we've picked it up on PET CT, where we've missed it on CT. There may be other tests applicable, sex-specific tests as outlined here, and there's some others outlined here. And then just to remember repeat images, I know one of my patients came in to see Luis Alcarla Zermeno in the hospital with a relapse of ANA1 associated neuropathy, and he emailed me and said, why don't we get another PET scan? And it was the right answer because the patient's cancer was initially not evident, but we were able to pick it up at that time. Autoimmune encephalitis is now seen in some novel settings. So we talked a little bit earlier about herpes simplex virus encephalitis. About a quarter of patients with herpes simplex virus encephalitis, potentially because it's so destructive to the temporal lobes, and there's a lot of antigens floating about, that you get an immune reaction in those patients, and they can have symptoms similar to a clinical relapse of that syndrome, and they can respond to immunotherapy and have positive antibodies. Dr. Zakariou has led much of our work in our lab of the CNS complications of immune checkpoint inhibitors, and Dr. Dubé on the peripheral nervous system complications. But these patients can sometimes present with autoimmune encephalitis. And then post-transplant, we've recognized a few cases in the post-transplant setting who had autoimmune encephalitis, potentially from mostly T-cell immunosuppression and an imbalance in immunosuppression in those patients. So it's something else to look out for. Just a few cases we have seen that, but certainly the top two we encounter not infrequently. So now just to mention about the diagnostic criteria for autoimmune encephalitis. This was published by Grouse and colleagues and Dr. Dalmau leading this in Lancet Neurology in 2016. And there are some parameters here that we'll come back to later, but these patients can have a diagnosis can be made when they have all three. So they have to have a subacute onset, of either with rapid progression of working memory deficits or short-term memory loss, altered mental status, or psychiatric symptoms. They may have CNS, focal CNS findings, seizures, CSF pleocytosis, or MRI, and then exclusion of other causes. These criteria are kind of complicated, so they have a diagnostic algorithm where you work through the algorithm, but you have to start off with the possible autoimmune encephalitis. If you don't have that, you can't meet any of the other criteria. And then you go down through the list and you can meet NMDA receptor encephalitis criteria. You can meet Bickerstaff's, you can have seronegative criteria. And then at the end, you of course want to reconsider the diagnosis. So it's a little bit complicated, but just to mention the possible autoimmune encephalitis, we'll come back to this, you need to have that to fulfill the criteria. So what about autoimmune encephalitis misdiagnosis, which I'll focus on over the next 9 minutes or so. So just to remember, like I mentioned earlier, mimics are more common than autoimmune encephalitis. It's still a rare condition, and toxic metabolic etiologies of encephalopathy will be more common, particularly in hospitalized patients. Psychiatric diseases like schizophrenia, depression with psychosis are going to be more common. Neurodegenerative conditions are more common. Infectious may be similar. And then some patients will have a non-encephalopathy where they might have a brain fog, for example. We'll talk a little bit about that. There's been many studies on patients who had autoimmune encephalitis and were initially misdiagnosed as something else. But there haven't been many studies on patients who were given a diagnosis of autoimmune encephalitis and that diagnosis was not correct. And that's a focus that we'll focus on over the next few minutes. And we see these cases come through our clinics and we see them come through our triage. And there are risks to misdiagnosis, including immunosuppressant treatments in the setting of the pandemic, as well as diagnostic delay for the actual diagnosis. That delay in diagnosis can be problematic. So to look at this, we did an international multi-center study on autoimmune encephalitis misdiagnosis that was led by us here at Mayo Clinic. And then we worked with UCSF, Oxford, UT Southwestern, University of Utah, and Washington University to look retrospectively at all these cases. And we included adults, so we focused this on adults, and we looked for patients who had a prior diagnosis of autoimmune encephalitis and subsequently had an alternative diagnosis assigned. And that may have been definite if they had a biopsy-confirmed glioma, for example, or probable where we don't have a specific test like a primary psychiatric disease. We excluded cases who are along the spectrum of autoimmune encephalitis, like CNS vasculitis or Susac syndrome. We were trying to get at really those cases where the diagnosis was incorrect, because some of those other syndromes, the term autoimmune encephalitis is still used. So this was a retrospective study. And what we did was we asked each center to look over their cases and see how many they had misdiagnosed as autoimmune encephalitis, and then also try and get a number of how many had true autoimmune encephalitis. And we collected their clinical, laboratory, and neuroimaging data, and we looked to see if they fulfilled criteria, the possible criteria, as we mentioned, and then we collected the final diagnosis in these cases and the reasons for misdiagnosis. And we also looked at treatments and adverse effects. So Mayo, not surprisingly, had the largest number of patients. We had 44 patients from Mayo, and then we had a variety of numbers from the other centers for a total of 107 patients. And over the same time period, about 336, so 3 times as many had a diagnosis of true autoimmune encephalitis. The median age was 48 years and females slightly predominated. And if we look at some of the clinical features, there were some clues here that might suggest that they did not have autoimmune encephalitis, including an insidious onset of symptoms was more common in these misdiagnosed cases. The frequency of seizures was low. That would be much higher in general in autoimmune encephalitis, probably 60–70% we would expect. The frequency of CSF pleocytosis was low at 19%. And the MRI brain overlapped with encephalitis in just about 18%. And it was notable that 30% of patients, even during their symptomatic phase, had normal neuropsych testing. Some of these patients had brain fog, for example, in the setting of fibromyalgia or many medications, and we'll talk a little bit about that later. And just 28% fulfilled these diagnostic criteria that I mentioned earlier for possible autoimmune encephalitis. So the majority of patients in this study would not have fulfilled the diagnostic criteria for autoimmune encephalitis. And if you have a patient who does not fulfill those criteria, then you want to consider it a red flag. The median delay to diagnosis was 16 months, and I think there was two major categories of diseases. There was a non-neurologic, or what we think about as non-neurologic, like functional neurologic disorder. I suppose that's a bit of a misnomer, but these were in the category of psychiatric/functional disorders. Primary psychiatric disease like depression with psychosis, for example, schizophrenia, non-encephalopathy, as I said, patients with brain fog, fibromyalgia, medications. And then there were more definite neurologic conditions like we see here. Neurodegenerative conditions accounted for many, including cases of CJD and Alzheimer's disease, neoplastic, as I'll show some examples, and there was some others here that I'll show over the next slide. So here you see an example. This was a patient who was initially thought to have autoimmune encephalitis, had an expansile lesion that turned out, not surprisingly, to be a glioblastoma. This was a patient here with signal abnormality in the white matter with enhancement that turned out to have primary CNS lymphoma. This patient had white matter disease in the setting of HIV, a HIV leukoencephalopathy, but positive NMDA receptor antibodies by cell-based assay in the CSF. This patient had MELAS, and it's not surprising that those patients could mimic autoimmune encephalitis, as they tend to fluctuate with waxing and waning symptoms and attacks of encephalopathy. And then here's some examples of some neurodegenerative conditions. This was Alzheimer's disease with hippocampal atrophy, and this was a patient with Creutzfeldt-Jakob disease, picked up nicely by Dr. Dave Jones. The most common reasons for misdiagnosis were overinterpretation of a non-specific antibody or misinterpretation of non-specific or functional symptoms as being true neurologic, or the imaging was felt to be consistent with autoimmune encephalitis. Some of the antibodies that we saw elevated, we see TPO antibodies here, GAD65 antibodies. These were usually low titer. Voltage-gated potassium channel, where they were negative for the LGI1 and Caspr2. NMDA receptor antibodies in serum. Most of these were negative in CSF. And there's some selected others, like we can see here, the ganglionic, striational, N-type calcium channel, etc. There were some CSF antibodies elevated, but none of these had confirmation on tissue and on cell-based assay. And indeed, these were much less common that we would see CSF positive antibodies, but some examples here. The treatments, the majority of patients did receive a treatment, and these are the range of treatments that they received, and about 20% had documented side effects. Now, this was difficult to document, so patients may have had more side effects than this, but the most common side effects were related to steroids and included serious complications like psychosis, avascular necrosis of the hip, a gastric ulcer, and heart failure. So some of the discussion around this, from this study, we state that autoimmune encephalitis misdiagnosis is an important issue. It's encountered reasonably frequently in autoimmune clinics. The delay to diagnosis is problematic, and it could be underrepresented because some of these patients go through the triage system and they may not be accepted in triage if there's a suspicion for a misdiagnosis. And we had the two major groups. Just to think about some of the red flags would be an insidious onset, no inflammation on CSF or MRI, the presence of a non-specific antibody like TPO antibodies, or not fulfilling criteria for possible autoimmune encephalitis. There are some occasions when patients can have absence of inflammation in the elderly and don't fulfill criteria, so just you can think about that. Just to mention about TPO antibodies, these are not a very good marker. They're found in about 20% of elderly adults. And there are many other antibodies that we've now removed from our panels: the ganglionic acetylcholine receptor antibody, the striated muscle antibody, the PQ and N-type calcium channel, the potassium channel complex. None of these are on the autoimmune encephalopathy panel now. So I think we're trying to make improvements to avoid misdiagnosis here. Sometimes the titers can help with GAD65 and MOG antibodies. Higher titers are more specific, and sometimes dilutions can help. I won't go through this too much, just to say that if we test on one assay with a Western blot, that can be problematic. So to conclude today, we talked a little bit about some of the MRI features, hemiencephalitis, the CSF being useful, the EEG, the antibody testing, the immunohistochemistry and cell-based assay, particularly being the mainstay of what we use. We talked about the antibody targeting the cell surface versus intracellular targets, and the cell surface having a better prognosis and better response to treatment. We talked about some of the red flags in autoimmune encephalitis. We talked a bit about TPO antibodies. We talked about some of the other neurologic conditions that can mimic, like glioma and Alzheimer's disease. And then we also mentioned that patients, they might have a normal MRI, although there is a caveat that not all normal MRIs doesn't exclude the condition. I'd like to acknowledge many people who've worked on this. Dr. Lennon is here. This is our neuroimmunology lab, and she set up the lab many years ago. So any of these studies are all down to her and her collecting samples over many years. Dr. Sean Piddock is there, who's my primary mentor. And then there's many other directors in the lab, Dr. LaChance McKeown, Dr. Dubé, Dr. Klein, and Dr. Zakerdu. And there's been many fellows and residents who've worked on many of these projects over the years who've helped us out. So I'd like to thank all of those. And then the acknowledgements for the multiple other centers that were involved in this misdiagnosis study, including Andy Solomon at the University of Vermont, who helped us out with this, who's done some work on this in MS.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.